Welcome to everyone. I'm stepping in for Joe Buxbaum. I'm Antonia New, and I am incredibly delighted to introduce Mercedes Perez here. I think many of you know her, but I can tell you from she's received her MD and PhD in Madrid. Her PhD was in the genetics of suicide, and she fell in love with the field of psychiatry. So she had the opportunity to come and do research here under the guidance of Maria Oquendo at Columbia. And we were fortunate that she chose to stay and get her clinical training here at Mount Sinai. So she was a resident here at Mount Sinai and was in the inaugural class of the physician scientists track at Mount Sinai, along with Panos Roussos. Mercedes is an incredibly accomplished researcher, an incredibly accomplished teacher, and she's very broad in her interests, but today is going to talk to us about a new area that I'll tell you in a minute. But before I say that, I will say Mercedes has many hidden talents. She's a polyglot. She is an incredible, it's obvious that she has an incredible intellectual capacity. What people may not know is that she's among the most generous people and warm people I've ever met. So I'm pleased to call her my friend. So let me introduce her, that she's also going to talk to you today about a relatively new area of research. She's got applied for a grant, and I will say at this point, I don't know if you have the notice of award, but she got a first percentile on this R1 grant on the cerebrospinal fluid biomarkers of perinatal psychopathology in a pregnancy cohort, and we'll hear much detail about this. But Mercedes, I incredibly look forward to your talk and every day enjoy having you as my colleague. Thank you.
Thank you so much, Antonia, for this wonderful introduction. And let me see if I can share my screen and show the talk. So, okay. Can everybody see it in the, I guess I can only see the.
Yes,
perfect.
I think yes,
excellent.
yes.
Okay, so and I want to thank also Joe Buxbaum for inviting me, and I'm really excited to be here, and it's a pity that this is not in person. I cannot see your faces, but I look forward to your questions at the end of the presentation. So the talk today, as Antonia mentioned, is about a very special project that we started working on about 3 years ago. It's a pregnancy cohort that we have been able to set up through a collaboration between psychiatry, obstetrics, and anesthesiology. And in this pregnancy cohort, we now are able to collect cerebrospinal fluid, or CSF, at the time of delivery, and then link these CSF central biomarkers to peripheral changes and neuropsychiatric symptoms. And in this cohort, we also administer the state-of-the-art psychiatric diagnostic rating. So we use the SCIB, both a categorical and a dimensional version. And we also get cognitive measures with a cognitive battery. And both of these we do in third trimester of pregnancy and at 3 months postpartum. So these are my disclosures, which are not related to the current presentation. And the work that I will be discussing has been funded by several different sources. So first, we were able to set up these CSF collection procedures at delivery, thanks to the Research Scholar Award from the Friedman Brain Institute. Then we were able to build on the recruitment resources and infrastructure. So we harnessed a larger cohort funded by the CDC. This is the Generation cohort. And building on this cohort, we used departmental pilot funds to launch our pilot CSF cohort, which we call Generation CSF. And I will talk about the cohort in more detail in a minute. But before, I really want to mention and acknowledge, so this is my labs team. And particularly, I want to highlight the stellar work of some lab members in this project. So Emma Smith, my research coordinator, she really has been instrumental in running this pilot project and has recruited over 120 pregnant women in about a year in the middle of the pandemic, right? So all of those of you who are doing clinical research and you know how hard it is to recruit and to run subjects, you can admire Emma for this work, and you know what I'm talking about. Moreover, because this is a pregnancy project and deliveries happen at any time of day or night or weekends, our staff has also had to be on call many days to coordinate sample collection for deliveries that happen at these non-work hours. And also, thank you to the rest of the team, our students, trainees, volunteers, Dr. McClure and Dr. McMean. And these are our collaborators, right? So I want to spend longer than I normally would on this part of the presentation before getting to the science, because really this project would not have been possible without all of these multidisciplinary collaborators. So from the Department of Psychiatry, we have our women's mental health experts, including Drs. Berging and Robakis, our immunologist and MPI of the project, Dr. DeBeat and her lab, and also Brett Collins, actually from Dr. Buxbaum's lab, who really was instrumental in setting up the project. Then, of course, the project would not be possible without Dr. Katz from anesthesiology and his team, including the OB anesthesia fellows, because they are the ones that collect CSF at delivery. Then the Department of Obstetrics, Dr. Dolan, who has supported us from the beginning of the project, and also Drs. Ramirez Zamudio and Giselle, and the whole Generation C team, because really our grant has been only possible and feasible because Generation C, the larger cohort, already existed. So this is the grant that Antonia and I have been talking about. And this is a narrow one that is scheduled to start in April of this year. It got a really good score, so we're confident we should be getting the notice of award very shortly. Dr. DeVitt, who you can see in the picture, and I are the multiple PIs of this grant. And many of the collaborators that I listed in the previous slide are co-investigators. And again, as I said, this grant really builds on the CDC-funded Generation C pregnancy cohort. So the overall goal of this grant is to investigate the impact of COVID-19 infection on inflammatory markers in CSF and blood at delivery, and then look at their role on the link with the subsequent cognitive and psychiatric sequelae in the postpartum period. And this is our overall model. So we hypothesize that exposure to the virus can lead to dysregulation of both peripheral and central inflammatory processes in pregnancy, and also to induction of autoimmunity, for example, neuronal autoantibodies. And this mediates the onset of psychiatric symptoms and cognitive dysfunction in the vulnerable postpartum period. We also will explore the role of other risk factors like low SES, or what role different race and ethnicity or psychiatric history play in these outcomes, as well as the role of moderators. So now that I have talked a little bit about the Generation CSF project, I want to rewind in time and discuss the reasoning for why this project is important and what we can learn from it. So first, I will discuss the evidence on pregnancy and the postpartum as high-risk periods for development of psychopathology and also cognitive impairment. I will talk about the pregnancy and the risk for COVID-19, particularly for severe disease. I will also talk about long COVID and neuropsychiatric sequelae and what we're increasingly understanding about this emerging field. I will then introduce the parent cohort, Generation C, which is funded by the CDC. I will also talk about how we set up this CSF collection at delivery as really a window into brain health and disease. And finally, I will present some of the preliminary results from the pilot that we have collected in this past year. So pregnancy and the postpartum, as we all know, are very special periods, and women undergo, or individuals who get pregnant undergo many changes. And these periods, unfortunately, are associated with an increased risk for experiencing psychiatric symptoms. So at the lower end of the spectrum of severity, we know that it is very common to experience mild depressive symptoms and mood swings in the postpartum period. And these have been termed maternity blues or baby blues. So you can see in this graph that anywhere between 10% and 75% of individuals will experience these symptoms. And this is across continents, so these are studies in different countries. And while this maternity blues is very common and is not considered pathological, conversely, postpartum depression is found less commonly in about 10% of women or less, depending on the country, and it can cause significant distress and impairment and affect caregiving for the infant as well. So here you see in the US, the CDC estimates that about 13% of women overall will have symptoms of depression after the birth of a baby, and these rates differ across states. When you look across countries, you can see that it appears that maybe the prevalence is affected by socioeconomic inequalities and also cultural factors. But overall, it ranges between about 3 to 5%, and in the countries with higher prevalence, even 40%. And at the most severe end of the spectrum, we have the most severe psychiatric disorders that can occur in the postpartum period and in the peripartum period are postpartum psychosis. And what you can see here is that the rate of psychiatric admissions in women is highest, particularly in the postpartum period. So these are months before and after childbirth. And this is a study that looked at over 800,000 children born by 500,000 mothers. And they found that the time of delivery really acted as a trigger, or could act as a trigger for psychiatric symptoms. And this is psychiatric admissions, right? So we're talking about the higher spectrum of severity. And in fact, there's also a growing literature suggesting that what we may have heard about as baby pregnancy brain, it may actually be true. So cognition seems to worsen during pregnancy, as you can see in this meta-analysis. And the effect sizes are quite large for some domains, for example, the memory domain, which is an effect size of about 1.5, which is large. And the next obvious question is, well, if there's all this risk for psychiatric disorders and maybe cognitive changes between pregnancy and in the postpartum period, why are these high-risk periods, right? So multiple changes occur during pregnancy and the postpartum. And some of them are very dramatic changes, for example, in the hormonal landscape. In fact, pregnancy represents physiologically one of the most profound or drastic adaptations of the human body. And it has been compared to that of an ultra marathon, only of course pregnancy happens over a longer period of time. And then I want to highlight that there are also sleep alterations, right? So taking care of a newborn is stressful and it disrupts your sleep, and then the impact of psychosocial factors and social support. And what this slide outlines is the changes in hormones that occur during pregnancy and after delivery. So what you can see is that the sexual hormones, progesterone and estradiol, they increase tremendously during pregnancy, and they decrease suddenly, almost like falling off a cliff after delivery. And these are actually neurosteroids that cross the blood-brain barrier and have effects by binding to neuronal receptors. The stress hormone cortisol follows the same pattern, and then oxytocin and prolactin have special roles in lactation in the postpartum period, and they both are believed to have an anxiolytic effect. So actually, all these hormonal changes may play a role in this high risk for psychiatric symptoms and cognitive changes in pregnancy and the postpartum. And here we also have another thing that changes during pregnancy, and this is the immune system. So the immune system really undergoes drastic changes as well, and a key goal of these adaptations is to avoid negative immune responses that may be detrimental against the fetus. And here you can see that cytokine levels, this is for inflammatory cytokines, and this is for anti-inflammatory cytokines. Their relative concentrations also change by month of pregnancy. And these are influenced by comorbidities, like, for example, maternal obesity, smoking, also multiparity, and even fetal sex. So pregnancy, not surprisingly, because of these immune changes that we just reviewed, actually is also a high-risk period for infections, including COVID-19. So pregnant women are at risk not just for COVID-19, more severe disease, but also for more severe disease, and this has been known for a while, for other illnesses, including influenza, malaria, or hepatitis E. This is the data, and again, this is the most recent meta-analysis from 2022, but this figure was nicer to show. This is from the Nature Reviews paper 2021. But basically, you get the idea. What you can see, and this is the percentage affected, and this would be pregnant women with COVID-19 in red and pregnant women without COVID-19 in blue. What you can see is that the percentage or the risk for all of these negative outcomes, including ICU admission for the mother, maternal mortality, preterm birth, neonatal death, are all higher among women with COVID-19 compared to those who do not have COVID-19. And the more recent meta-analysis, which included over 40,000 COVID-19 positive pregnant women, it does find increased risk, for example, for premature delivery with an odds ratio of 1.5, preeclampsia, an odds ratio of 1.6, and maternal mortality and neonatal mortality with odds ratios above 3. So very significantly, COVID-19 impacts pregnancy and neonatal, maternal and neonatal outcomes. And while COVID-19 infection during pregnancy can affect multiple organs, as we can see in this figure, I will focus today on the psychiatric and cognitive sequelae. So what is long COVID, or the post-acute sequelae of COVID, also termed PASC? And here you can see that, this is the acute COVID-19 that I think many of us are familiar with, different versions of this figure. So we understand that COVID-19 infection causes immune changes, immune abnormalities. There's something called a cytokine storm, and it seems that there's some overactivation and damage done by inflammatory processes. And even in mild cases, things like lymphopenia, for example, can last for weeks or months after an acute COVID-19 infection. But then increasingly, there's more and more data that suggests that there's also a post-acute viral syndrome. So there are, there's increasing data supporting that there are persistent, prolonged effects after acute COVID-19 that affect multiple organs, including the brain, right? So things like anxiety, depression, sleep disturbances, cognitive changes, PTSD, etc. And here we can see, so this is a study that shows the frequency of these post-acute COVID symptoms. And this is studies that only follow up patients for 1 month. They find a range of prevalence of PASC between about 20% and 80%. But then if you keep following patients, so this is intermediate is between 2 and 5 months, and long-term is 6 months, you still keep finding these changes. So these sequelae of COVID. And this is if we break it down by different types of symptoms, and this would be the frequencies. So for example, we can see a cognitive impairment between 10 and 50% of individuals, and much larger range and up to 80% or 75% with anxiety symptoms. And in fact, the American Academy of Physical Medicine and Rehabilitation has released an online dashboard that allows you to estimate the prevalence of PASC in the US. This would be this green line, sorry, this would be, and in New York State. So I selected the figure to show that this is in New York State. So the green line shows all COVID-19 surviving cases, and it's probably higher, right, because of underdiagnosis. And they estimate, with a conservative estimation of prevalence of 30%, would be that there's 1.5 million individuals in New York State alone that are suffering from PASC. And what are potential mechanisms of PASC, right? So things like viral reservoirs, maybe in the GI system, persistence of non-infectious viral fragments, immune exhaustion, viral-induced autoimmunity with neuronal autoantibodies, for example, abnormal immunometabolism and alterations in mitochondria, alterations in the microbiome, and also in the renin-angiotensin system. So all of these potential pathological mechanisms have been cited as causing post-acute COVID-19 symptoms. And how about the neuropsychiatric sequelae? Well, so there's changes that can happen to microglia due to a long-term immune activation. So this chronic inflammation may activate the microglia in a way that chronically will damage neurons. The hyperinflammatory and hypercoagulability that is found in COVID-19 patients may lead also to increased risk of these thromboembolic events. There can be blood-brain barrier damage as well, and then this may result in pathological permeability, so that blood-derived, for example, inflammatory cytokines and leukocytes may infiltrate the brain. And then there may be also autonomic dysfunction, and all of these things can cause psychiatric symptoms and cognitive impairment. So I now want to switch gears a little bit. We've been talking about, why it is important to study the impact of COVID-19 infection on neuropsychiatric symptoms, because they are very common in patients who have survived COVID-19, and they may represent these post-acute sequelae. And then also why it's really important to study them in pregnancy and postpartum, which are high-risk periods for infections and psychopathology. And now I want to introduce the CDC-funded Generation C cohort, which is this very large pregnancy cohort that was established in 2020, right after the first, or in the first peak of the pandemic in New York City. And these are the founding multiple PIs and the current multiple PIs. So it's a collaboration between psychiatry, obstetrics, and population health. And really our CSF study that I will come back to in a few slides has been built using the resources and the recruitment infrastructure from this cohort that has really served as an incubator for our project. And here you can see a summary slide for the Generation C study, and the target number is 3,500 pregnant women. They have now about 3,000. And the aim is to investigate the impact of COVID-19 and the cytokine storm, and also stress, social disparities, and so forth on maternal and neonatal outcomes. And they collect peripheral blood, and also in a second iteration of the project, placenta and umbilical cord blood at delivery, and link it with maternal outcomes and child outcomes. And these are the aims. So the first one is to establish the seroprevalence of the SARS coronavirus 2 with antibody assays at each trimester of pregnancy, and also the immune response with a set of cytokines. And then aim 2 looks at maternal outcomes and neonatal outcomes, and aim 3 focuses on the impact of social disparities and stress. So you can see here in this figure, and this is, you know, what was mentioned in the previous slide, but in a graph form. And this is a timeline of what is collected in the Generation C cohort. So as I mentioned, there's blood that's collected in each trimester of pregnancy. And then there are questionnaires as well that are administered to all women. And at delivery, blood is collected, but also placenta and umbilical cord blood. And then there's a postpartum follow-up with questionnaires as well. So this is some of the interim results from the Generation C cohort in terms of seroprevalence. So you can see that about 23% of women in this cohort had been, or individuals in this cohort had been exposed, had been infected by COVID-19 and had positive antibodies, and about 76% were negative. These are the numbers for placenta collection and umbilical cord blood. And now we get to what we added to this cohort. So why is CSF important? So one thing that I will mention is that, right, as researchers, it's very hard to access the brain, right? The brain usually in an individual who's alive, it has to be accessed indirectly. So either you do neuroimaging, or you do some peripheral markers that may tell you something about what's going on in the brain. And then the closest that most people get is through lumbar puncture to access the cerebrospinal fluid, which is the fluid that bathes the brain, and basically it's like in closest proximity with the organ that we want to study, right? And this slide that I'm showing is just an example of the explosion in studies that are interested in the role of inflammation in neuropsychiatric disorders. So both, mood disorders, psychosis, schizophrenia, Alzheimer's disease, and most of these studies, the vast majority, use peripheral markers. But so what's the issue with a peripheral marker, right? So you need to have a very good knowledge of how this peripheral marker correlates with any central measure that you're trying to assess. And in fact, how well peripheral inflammatory markers are associated with central inflammatory markers is not well understood yet, right? So the thing is that, many of these studies may be using or maybe assuming that the peripheral inflammation represents what's going on in the brain. And in some cases that may be true, and in some others it may not. And the problem also is that, accessing the CSF is normally an invasive procedure, right? So you need to do a lumbar puncture, and this is something that is, it's definitely more than minimal risk from the IRB standpoint, and not everyone will agree to this. And certainly you could not do this, for example, you would have to have very good reason to do this, for example, in pregnant women. Peripheral proxies are very important to ascertain. So we wanted to look at the correlation between peripheral and central inflammatory markers. And this is a project in collaboration with Lotte de Wit, and this was prepared by Emma Smith and Frédéric Gigas. And after a literature search, we could only find 21 papers that reported correlations between inflammatory markers in CSF and plasma in paired samples from the same person. And what we could find, and these are the results for a few of the cytokines, is that in fact of all of these, only one, IL-6, was significantly correlated between CSF and plasma. And this is not the case for all markers, but this shows that this is a field where we need more information, and that in fact many of the cytokines were not correlated significantly between CSF and plasma. So if you use plasma as a proxy of what's going on in the brain, maybe you are basing your assumption in actually a wrong assumption, right? Like there's no correlation between these other cytokines in CSF and blood. So this is the project that we got funded about 3 years ago that I mentioned before. This was funded by the Friedman Brain Institute, and it established the procedures for CSF collection in pregnancy. This is the founding team, and some members are still involved in it today. So Dan Katz, I want to give a shout out to. Dr. Katz is our anesthesiologist who leads the CSF collection with the rest of the anesthesiology team, Firle Bergings, who's still working on the project today, and Julie Spicer, who's the multiple PI of this pilot project. And what you can see here is that you can actually collect a CSF during the analgesia procedures that occur during a normal delivery. And this is actually, there are 3 of these procedures. So spinal anesthesia, combined spinal epidural anesthesia, and dural puncture epidural, which provide access to the CSF. So we recruit patients who plan to undergo these procedures as part of their routine clinical care. Therefore, in our project, we don't require participants to undergo any invasive procedures just for the purpose of our study, but as treatment as usual, they will get these procedures. And then the only difference is that the obstetric anesthesiologist who's performing the procedures will draw 5 cc's or up to 5 cc's of CSF for our study. And this leads us to the study that I mentioned at the beginning, the R01 that's hopefully about to be funded, which focuses on the cerebrospinal fluid and peripheral markers of the impact of COVID-19 on the brain. And we call this project the Generation CSF Pregnancy Study, again with Dr. De Wit as a multiple PI. So thanks to all the people that I've mentioned, all the collaborators, we were able to build a CSF cohort on top of the CDC-funded Generation C cohort. And here you can see, these are all the assessments in the larger Generation C cohort. And this is, in women so for the past year, we've been recruiting women who were part of the Generation C cohort, and we've been adding collection of CSF, 1 tube, 5 cc's at delivery, where we can look at inflammatory markers and also an additional tube of blood, and adding this psychiatric evaluation at 3rd trimester of pregnancy and at 3 months postpartum, and also adding the cognitive battery at 3rd trimester and 3 months postpartum. And this is our timeline. So we can see there's an exposure period, which is until delivery. And what we, in this exposure period, women can be exposed to COVID infection, to the COVID vaccine, or not be exposed to any of those two. And through the Generation C study, there's a tube of blood that is drawn in each of the trimesters of pregnancy. And then as part of Generation CSF, there's also a tube of CSF and blood that is obtained at delivery. And then our outcome, which happens after delivery, are postpartum measures of psychiatric symptoms and cognition. What we hypothesize is that prior infection by the COVID-19 virus can lead to the dysregulation of peripheral and central inflammatory processes in pregnancy, and also to the generation of neuronal autoantibodies. And this contributes to causing psychiatric symptoms and cognitive dysfunction in this vulnerable postpartum period that I described before. So these are our specific aims. So the first aim is to characterize this subacute and long-term impact of COVID infection on the central and peripheral inflammatory processes. So we hypothesize that there's going to be a dysregulation that will lead to changes in peripheral and central cytokines, and also to the development of neuronal autoantibodies. Then our second aim, we're examining the effect or the potential effect of COVID-19 infection on these outcomes of affective symptoms with the EPDS, which is a measure of postpartum depression, and on dimensional symptoms measured with the SCID, with the DSM diagnostic semi-structured scale, and looking at central and peripheral inflammation as mediators. And our third aim will do the same, but focusing on cognition as outcomes. So specifically looking at the impact on attention and memory and executive function, as these are the domains that have been found to be more impaired, both in pregnant women and in individuals infected with COVID-19. So this is our overall model, which I introduced before already. And again, we'll also look at all of these covariates or other predictors and moderators like anti-inflammatory medication or the timing of infection in terms of pregnancy trimester. So now that I have explained a bit about our project, I want to show you what we've done so far. So this is recruitment in our Generation CSF project. And we've recruited 123 women. You can see the mean age and the race and ethnicity distribution. We have about a quarter of Hispanic and Latina, and I should say that about 43% of our sample is non-white. Also a distribution in terms of insurance and pre-pregnancy comorbidities, and so far a rate of exposure to COVID-19 of about 18%, and a rate of vaccination which is higher than the national average for pregnant women and also the New York State average. So it's about 63% who are vaccinated. And what you can see here, and this is a work that Dr. DeVitt and Gigas did, was one of the things that we were able to show is that we can use different types of antibodies to distinguish between a COVID infection and a vaccination with one of the COVID-19 vaccines. So in this first group are those that were not exposed to the virus or the vaccine. And as you can see, they are negative for all the antibodies we checked, the spike S1 subunit, the spike S2 subunit, and also the receptor binding domain and the nucleocapsid protein. Then we have group 2. They are the ones that were exposed to the virus. They have a history of infection, but they have not been vaccinated, and they are positive for all of the antibodies. And then we have actually we have one outlier who is not, and we think this is probably because the antibody titers diminish since the time of the initial infection. And then the third group are those who are vaccinated, and they are positive for those antibodies that are elicited by the vaccine. So this is spike 1, spike 2, and a receptor binding domain, but not for the nucleocapsid antibody. So we plan to use this set of antibodies going forward to make sure that we can distinguish between women who have been exposed to COVID-19 infection or vaccination. And moving along to some more of our preliminary results, and I'll go a bit fast with this because I do want to have time for discussion. So this shows that for most cytokines, and this is in a subset of about 50 women, actually 43 paired samples, we have differences in levels between most of the cytokines, and we have significant correlations only in a subset, right? So for some cytokines, we don't have a correlation at all, or there's even a strong negative correlation. And in fact, for most cytokines, going back to the previous slide, the levels are higher in plasma compared to CSF, but there are some exceptions, notably IL-8. And this is one of our first questions. So do cytokine levels change, differ by COVID-19 status? And again, the caveat is that in this subset, we only had 8 women with previous COVID-19 infection, and we did not find any differences in cytokines at delivery in CSF or blood. And then what we did find are, and this is in women who were vaccinated at the time of delivery, so anytime during pregnancy or before pregnancy, and those who were not vaccinated, we did find differences in cytokine levels, both in plasma and CSF. And this summarizes these results. So this is for plasma and this is for CSF. And in the next slide, I will show also our preliminary, again, very preliminary, because this is actually only a subset of the sample that we have the cognitive data analyzed. But what I want to show here, and again, this is the CANTAB battery, and these are different domains of cognition that each of these tasks assess. So for example, rapid visual processing measures attention, and spatial working memory is a memory task that focuses on working memory. These are T-scores, so there's a mean of 50 and a standard deviation of 10. So what I wanted to show is that our women are, comparable to the general population. This is standardized data, and on some domains they're doing a little bit better than the norms for the population. There are unfortunately no norms yet for pregnant women. And here what you can see, and I thought this was interesting to show, this is in 8 women for whom we have a 3rd trimester and postpartum data. And again, this is very preliminary data because it's a very small group. But what we can see is that there are changes in cognition, and this is across participants. So each of these points is one participant, and these are C-scores. So units are standard deviations here. So you can see that between the 3rd trimester in purple over here for these 2 domains of cognition and the postpartum in yellow, what we can see is that there are improvements in these domains, which range between 0.5 and about 1 standard deviation. And this would be consistent with the literature, which this meta-analysis that I showed you, that shows a decrease in cognition during pregnancy, particularly in 3rd trimester. So because we're comparing 3rd trimester with postpartum, what we're seeing probably is the rebound to the normal levels of cognition after delivery. And then finally, also preliminary data, again in a subset, is that racial minorities we found were less likely than white individuals to be vaccinated. Hispanic individuals were also less likely to be vaccinated and were more likely to test positive for COVID-19. And things like being employed, having private insurance, or having a postgraduate degree were linked to higher likelihood of vaccination. And I want to discuss briefly some of the future directions over just the next minute or so, and some of the future collaborations, right? So one of the first things we would like to do, and we plan to submit a supplement, it would be to characterize the immune cell populations in both CSF and blood using single cell RNA-seq and mass cytometry. And this is a collaboration with Drs. David and Jiseon Seo, proteomic changes in CSF and blood and multi-level omics to try to understand a bit better what changes COVID-19 causes in these processes. Then also a planned R01 submission. This is actually the project that started everything, the one that was funded, the pilot that was funded by the FBI, focusing on cerebrospinal fluid biomarkers of mother-infant social behavior with a focus on oxytocin and vasopressin. And then to establish a new pregnancy cohort is enriched for patients at high risk for postpartum psychosis, in collaboration also with Viola Berging and Talia Robakis and Lot David. So thank you. And are there any questions now? I should stop my share.
Yes, and I'm going to step in and say that I should have said at the beginning that questions are best asked through the Q&A. You can see the Q&A at the bottom of your screen. Thank you so much for a wonderful talk, Mercedes. It's amazing work, an amazing accomplishment to have gotten that cohort. And so people coming in with Q&A, I will help with making sure we can see anyone who has questions. I'm going to start by saying for myself, the data on the effect of the decrement in estrogen is very interesting, sort of as a normative fact that immediately postpartum. Oh, great overview from Shirley. Yes, I mean, that is sort of an amazing fact, and one that, I just was talking today about a patient who with breast cancer was receiving an estrogen blocking agent, and we were looking to the literature because maybe this falling off a cliff has an impact, and it will be very interesting to see if you can characterize some of the impact of the inflammatory processes and other things. Amazing. So, okay, so let's see. Exciting and wonderful studies consider microbiome and childhood trauma. Leaky gut is normal and physiological in pregnancy. Okay, that's a scary thought, but probably right. Great talk. Have you considered querying pregnant women who have not been vaccinated, what their reasons might be for not doing so? Yeah.
So yes, so actually this is a great question, and this is something that I am actually not 100% sure if this is already asked. I believe it's asked by Gen Z. If you are a Gen Z, oh, perfect. I see. Yeah, we're working on that in the Gen Z cohort, exactly. So yeah. This is something that is certainly of interest.
Yeah, I mean, so one of the things I thought is this has got a highly political element, right? Because one of the pieces of misinformation out there is the destructive nature of the vaccine, sort of for obviously fertility, which your talk doesn't speak to directly, but the misinformation about the destructive nature of the vaccine to the baby. And mm-hmm. I think I'm wondering whether in your reviews for the grant, there was any element of that kind of politics leaking into the reviews.
So one of the things that the reviewers commented, it was actually they recommended.
By the way, they're saying, will you look at neonates? That's a part of that question.
Oh, so yeah. So and actually the neonate, so there's a separate grant that is being reviewed, I think sometime next week, that actually the PI is Dr. Rommel, and that is focusing on the neonates. And then there's another grant that focuses on following the mothers. And then there's yet another grant that's being reviewed in March that's focused on placenta. And I probably am missing some, right? Because many grants have been sprouting from this Generation C cohort. But going back to your question, Antonia, one of the reviewers did a request. So again, to think about this, right? The grant was submitted for the first time in 2020, not long after the the first COVID peak. So there were no vaccines. So we did not include the vaccine as an aim or sub-aim in our initial submission, but then at the time it was reviewed, the vaccines were becoming available. And one of the reviewers did ask us to include vaccine effects.
Right.
And we very gladly added that as a sub-aim, because we also felt that it would be important to show both negative and positive results, right? Particularly, we can show that nothing wrong happens if you are vaccinated, then that may decrease anxiety in pregnant women who may be hesitant to get vaccinated.
Right. So there are a few more questions. Ron Reeder asked, have your data now led to some major hypotheses which will guide you in the future?
Well, so I mean, basically what we have is very limited data still, right? So we haven't been able, and we're taking everything with a grain of salt in this interim analysis, you know, of 43 paired CSF and blood samples. There are some things that have guided our research, for example, finding that, you know, 3 of the cytokines in our panel of 14 were actually not well detected in CSF, right? So for example, those cytokines we've removed from a future analysis, but we don't yet have any big next hypothesis. What we want to do is understand mechanism better, and that's why things like proteomics and multiomics and single cell RNA-seq would be important.
Yeah, so Viola Berking says, can you comment on the control groups for the papers on adverse cognitive and behavioral outcomes after COVID?
Well, that is an excellent question, because most of these papers do not have controls that have been affected, for example, by other infection. And there's, I mean, and I know that we have actually a site for studying long COVID, the past recover cohort, and this is led by Alex Charney, and I forget who the other PIs are at Sinai, so they may know more about what, like in comparison to other control groups, what control groups they're using for the nationwide long COVID cohort, because I'm not aware of what control groups they're using, and this is still ongoing.
Right, so Dolores says long COVID pro-inflammatory effects are associated with childhood adversity. Yeah, that may well be shown. Joe added to his question about how long is the longest follow-up of the kids. I mean, that of course is going to be really important, right? Is, it's one thing to see, APGAR scores or sort of how do babies, meet their first requirement. Another thing to look at, how do kids go when they get to be 5 years old and are going to school and that sort of thing. That's going to be obviously a long-term, that's not a study we can do right away. It's going to be a very expensive study, but I presume in the people following the neonates, they plan some degree of follow-up. I don't know if you know the answer to that.
Mm-hmm. So I don't know the exact, so if anyone is here who knows for Dr. Rommel's grant what the follow-up period
She's just right. We're planning to follow up to 3 years old. Okay, wonderful.
Excellent.
Yeah, and so already then many of the sort of early developmental milestones will have been, achieved or not at that point.
Mm-hmm. Well, and I mean, I think that this is the type of project, right, that, I mean, it sounds to me like a center grant with multiple components. So I don't know, and I'm happy to discuss collaborations or brainstorm, because this is something that is certainly worth following.
Yeah, I mean, from my perspective, listening to this and to the different pieces of this that came together, I know you spent longer than usual on, thanking the collaborators. And it does strike me that there's a lot of things that went into the more basic, like how do you begin to get the data on the cohort? And once you begin to have a pathway to gather this, there's so many questions to ask. And it's really incredibly exciting. And I hear that Anna Rommel is saying hopefully longer than that. Yeah, I want to hear about them when they go to school. That's my, how are the 5-year-olds doing is my question. Well, any other questions?
We just saw, so Anna got that 12th percentile. I mean, so this is, congratulations.
Congratulations, is, fantastic. Yeah. Okay.
We're getting this in real time.
In real time here, excellent, okay. And from look, all of us, very exciting. Yeah, this is really, really exciting work. It's really fun for me to hear how so this part of our department is really developing into sort of it must be one of the very few centers that has the ability to do this work, and it's incredibly important, incredibly exciting. So I am, let's see, happy to find out if there's any more, but I think we may not have more questions. Mercedes, thank you so much for this talk, really wonderful talk. And thank you, Joe, for giving me an opportunity to moderate and hear and be a part of this this project. I would have been a listener. I'm happy to be a participant. Thank you. Okay.
Well, thank you,
Take
everybody,
care all.
and,
Okay.
and thank you to all the
Mercedes.
collaborators.
Thank you so much.
This has
Okay.
been great.
Bye. Bye. Bye.